Today we talk about what would I do if I was 38, trying for a year, and every test came back normal, and I still was not pregnant.
I'm Dr. Mark Amos, and this is Taco About Fertility Tuesday.
If that opening line is you, know that you're not crazy and you're not alone and you're not failing. You're stuck in one of the most frustrating categories in fertility, that everything looks fine group, yet nothing is working. And here's something that may annoy you. Unexplained infertility is not a diagnosis. It's a label. It basically means we didn't find the problem with the test we ran. So today, I'm going to give you a step-by-step plan. Not a motivational poster, but a plan. And keep in mind, this is educational. It is not direct personal advice, so use this as a framework to have a smarter conversation with your doctor. So let's start first with why normal isn't reassuring at age 38. Here's the core reason. Because you're 38. See, most fertility tests are going to measure things like the quantity. It's going to measure things like if the plumbing is working, such as your tubes. But what they don't do is they don't directly measure the biggest invisible factor, your egg quality. When it comes to AMH, follicle count, yeah, they tell you the inventory, but not the quality. Tubes may be open, doesn't mean they function perfectly. Even a semen analysis can look amazing, but while the sperm may look amazing, the DNA may be a mess. And here's the big thing. At 38, time matters more, because the probability of a chromosomal issue in the eggs rises as we get older. At 38, 60% of the eggs are usually going to be abnormal. Now, the good thing is, it doesn't mean that pregnancy is impossible. It means you don't want to spend the next year staying positive as your main intervention. Essentially, hope is not going to be our strategy. It's going to be the vibe. But strategy is what we're building. So if I'm 38, trying for 12 months, and tests are normal, my first move is not to panic. My first move is to ask these questions. Am I ovulating? Not just my abs saying so, but am I actually ovulating? Sure, regular cycles are a good sign, but it's not proof. If you want objective confirmation, a mid-luteal progesterone level, or even an ultrasound during the ovulation phase can help you know this. Next, confirm that your uterus is a good place to land. Just because you have had a normal ultrasound does not mean you have a normal uterine cavity. I hear this all the time. Oh, my doctor already did an ultrasound. I say, well, that's great. That doesn't mean the inside of it looks good. It just means that outside looks good and they don't see anything obvious. What you want at that point is a sonohistogram. This is going to allow you to look for polyps. It's going to allow you to look for things like fibers that are pushing into the cavity or even scar tissue that wasn't easy to see. This is the place you're going to grow your baby for the next 9 months. You want this place to be a 5-star hotel. You may look healthy, you may be fit, but that doesn't mean the room that they check into looks great. Next, I would want to make sure the tubes are open. An HSG is one of the most common tests, which stands for hysterosalpingogram. This can be done a few ways. One, you can actually take a dye that is contrast. It is clear looking, but it has a high level of iodine in it, which is radiopaque when you do an X-ray. And so when they push this through your uterus, through the fallopian tubes, they can see the dye coming out. This tells us the tubes are open. Now, the other ways you can do it is there's even a test called X-foam or HIFO-C, which uses foam or irritated saline that can be seen on an ultrasound while it's being pushed through the uterus and the fallopian tubes. The last way is one of the gold standards, which is called a chromoperturbation, which is when you're undergoing a surgery, they can actually put methylene blue or indigo into the uterus and it goes out the fallopian tubes and we see a blue dye come out of the fallopian tubes verifying the tubes are open. Now, only the chromoperturbation allows us to also look at the fallopian tubes to make sure the ends are normal in anatomy, but still doesn't guarantee function. If you had a history of pelvic infection, surgery in the past, appendicitis, or endometriosis, there's a chance you may have a blocked tube or blocked tubes. Additionally, sometimes you can have a hydrosalpinx, which is a fluid-filled tube, which can also lower your chances and cause infertility. The point is, open tubes are good, but open tubes do not guarantee perfect tubal function. Next, confirm that all the boring labs were actually done and are still boring, such as your thyroid, prolactin, hemoglobin A1C if you're at risk for insulin resistance, vitamin D levels, or anything else that your situation truly warrants. Not because these are going to explain infertility, but because when they matter, they do matter. Think of these tests as a test that aren't diagnosing, but they are removing the landmines that may show up. And then last, make sure you look at the male side of things. No one can have unexplained infertility if they haven't had a semen analysis first. And make sure that semen analysis is read by someone who is a reproductive specialist. Many times I have seen people get semen analysis told they're normal by their OB doctor and end up having actual issues. So when that semen analysis is borderline and the doctor says, oh, it's good enough, no, it's not. Repeat that semen analysis because that borderline may be the best day ever they had, and it may be much worse than that. And if the semen analysis does come back normal, and in certain situations, just like borderline semen analyses, recurrent losses, failed IVFs, history of smoking by the male, or high heat exposure, then in that situation, and especially older men, it may be worth even getting a DNA fragmentation test to verify the viability of the sperm. So let's talk about what could be going on even when the basic tests are normal. Number 1, egg quality, also known as chromosomal issues. This is the most common invisible factor at age 38. You can have great cycles and still have many eggs that don't make it to embryos capable of becoming a baby because of DNA issues. Number 2, subtle sperm issues. Not just count and motility, we're talking DNA integrity matters. This is where that DNA fragmentation comes in. Number 3, endometriosis. Yes, even without classic symptoms, not everyone has severe pain. Endo can impact the pelvis. It can cause inflammation and implantation issues. It can affect your egg quality and even your tubal function. Now, it's important to understand just because we suspect endometriosis doesn't mean to jump to surgery. Think of surgery as a tool, not a reflex. When we suspect endometriosis, we may make adjustments, but we don't always need to diagnose it just to be able to treat it. Number 4, tubal function. As I mentioned before, just because the tubes are open does not mean they're great at doing their actual job. And unfortunately, there is no test to verify that. That means if this is your issue, things like IUI will never work, and IVF will have to be used to have success. Number 5, uterine cavity microproblems, such as small polyps or subtle adhesions, or inflammation that's not known. These things don't show up on a standard ultrasound, which is why you need to do a sonohystogram to really evaluate these things, or a hysteroscopy, where we can put a camera inside the uterus and look for some of these issues. And number 6, timing issues. This is a little more common than people think because, well, life happens. There are things like travel issues, missing ovulation timing because you guys are in the same place at the same time, sometimes even just having intercourse way too early or way too late or too infrequently. I've had people who said, I've been trying a year, but when I really look at the timing, I realize they've had no chances because they were doing it the wrong time. So far we've talked about 2 of the steps I would have done if I was in this situation. First step, confirming the basic tests have been done. The second step is think about the common hidden causes that can be occurring, but without going down the rabbit holes. Which leads me to the third step. What I would do next if I was 38 and had normal tests but was still not pregnant. And this is where we get into the money part. When I say money, I mean the part that costs money and emotional energy. The way I would think of this is a different paths that we can take. If you're not wanting a lot of kids, you may want to go slow. But if you're wanting several kids and you're 38, you know you don't have a lot of time. And so maybe your first path is, I want the fastest route to pregnancy. If speed matters, the plan is typically this. Don't do endless low-yield cycles of IUI because they're just simple. Use the option with the best chance per month. This usually means going straight to IVF. Now why? Well, one, it does give you higher odds per cycle because you're 38. It allows you to get a lot of eggs, which would usually take over a year to get that many eggs. But it also gives you information. I've said before on my podcast, IVF is not just a treatment, but a test. It gives you information about the fertilization, about the embryo development, and potentially even genetic testing that may lead you to find you have genetic issues that are causing problems. Don't always think of IVF as the last resort. Think of it as the most efficient route for some people. Now, where does IUI fit in? Well, if you find there's a small sperm problem that would explain the infertility, then it makes sense to start with the IUI. But if your egg reserve is not good, it wouldn't make sense to start with. If your tubes are blocked, again, it wouldn't make sense to start with. So it's not unreasonable to do IUI, just if you want the path of the fastest route to pregnancy, it's probably not going to be your best step after for a year trying and not getting pregnant at age 38. Now the second path is going to be path 2. This can be the situation where maybe you're budget sensitive and you feel like, hey, I can give it a few months. I'm only wanting, let's say, 1 kid. Maybe 2 at the most, but I'm not worried about preserving fertility. So this is let's try a few steps before the IVF path. My typical framework in this situation is going to be 1 to 3 cycles of IUIs. If the ovarian reserve is very good, I may just use letrozole or Clomid. If the ovarian reserve is poor, I'm probably going to add some injections to help improve the chances. I personally do not go with timed intercourse if you've had a year of trying on your own already. Now, if you're not ovulating, that's a different story. Timed intercourse then can make sense because you weren't ovulating before. But if you've been trying for a year and you've been ovulating, timed intercourse is going to be a waste. But here's the hard stop rule. If you are not pregnant after 3 IUI cycles, you need to escalate this. Doing a few more cycles is probably not going to get you there. Prior studies have shown that after 3 IUIs, if it hasn't worked, statistically, 90% of the people who it was going to work for already are pregnant, and only 10% get pregnant after that. And maybe those other paths weren't for you. Maybe you want this third path, which is I'm emotionally fried. I want minimal intervention. And this is real, and it's very valid. But minimal intervention should still be structured, not endless. I would recommend no more than 3 cycles of objective ovulation tracking. And set a decision date. You need to have a plan and a time to stop. You don't ever have to move on to IUIs or IVF. But there is a point where you have to realize what you're doing is not going to work with minimal intervention. Well, I've told you what I would do, but what are my hard stop rules and what I would not do? At 38, after 12 months of trying and normal test, I don't support another 6 to 12 months of just keep trying, unless there's a very specific reason to, such as finding out you're not ovulating. If my ovarian reserve markers are low, or maybe even trending down fast, I'm not going to do IUIs because it's going to tax the time I have left to get pregnant. If I find the sperm is borderline or there's high DNA fragmentation, I'm going to be cautious about wasting cycles that don't really address the issue of the DNA fragmentation or borderline sperm values. And as I said before, if I'm doing IUIs, I'm limiting them to about 3. If it hasn't worked by then, I'm moving on to either IVF or some other treatment or test. Now, what do I absolutely not do? I would not buy a pantry full of supplements and call it a treatment plan. Yes, supplements can support, but they rarely fix core problems. Additionally, I would not chase immune panels and exotic tests unless there's an actual indication for them. Basically, if the plan is very expensive and the evidence is very thin, you want another opinion. And my last do not thing to do is jump straight to surgery just to look to see if you have endometriosis. Surgery does have a role, but at 38, doing surgery just to look won't just cost you money, but it's going to cost you time because you have to wait to then proceed with treatment. And if you have a complication, it could even be longer. So here are my 3 tidbits I would tell you to ask your doctor if you're in this situation. Number 1, what are the top 3 things we haven't ruled out yet? Number 2, given that I'm 38 and we've tried for a year, what is your escalation plan and timeline for me? And number 3, if we choose IUI, how many cycles before we stop and why? These 3 questions are going to help move things along versus having you get stuck in doing treatment after treatment without an actual plan. In the end, if you are 38, trying for a year, and have all normal tests, remember, normal tests don't mean nothing is wrong. It means we don't have the test to be able to figure out what's wrong at this point. And because you're 38, time is not on your side. And the goal is not to do everything and see what sticks when you throw it all at the wall. The goal is to do the right thing next and to do it quickly. Maybe you're 38 and going through this exact same situation, or you have a friend who's 38 and is dealing with the same issue. If you found this podcast helpful, please tell your friends about us and give us a 5-star review on your favorite medium. As always, I greatly appreciate everyone who listens to this podcast. If you want to send me a topic to go over, send it to tbft@newdirectionfertility.com. I'll be happy to do it in the future. I look forward to talking to you again next week on Talk About Fertility Tuesday.